歡迎大家嚟到今日。
Welcome to the press briefing. On stage, we have Dr. Albert Au, Principal Medical and Health Officer from the Center for Health Protection, as well as Dr. Larry Lee, Chief Manager from Hospital Authority. Dr. Au will give us an update of the epidemic. Good afternoon. I'd like to report to you the number of cases reported yesterday, the 3rd of May. For cases tested positive through PCR, we had 112 cases, 23 of which were confirmed by HA, 22 by public health laboratory, the remaining 69 by private laboratories. As regards RAT, yesterday there were 201 cases tested positive, reported and verified through the declaration system. We had 313 positive cases in total yesterday. In the fifth wave, we have confirmed 1.19 million, 2,765 cases, 744 cases odd were by PCR, 440 odd by RAT. For cases reported yesterday, 22 were imported. The remaining 291 were local cases. Among the 22 imported cases, 7 were identified at our temporary specimen collection center, including 3 arriving on the 3rd of May by CX2506 from Spain, France, and the UK. 2 arrived on the 3rd of May on PR980, both from Singapore. 1 arrived on the 3rd of May on SQ882 from Germany. The last case arrived on the 3rd of May on A1314 from India. We've got 13 cases identified at quarantine hotels during quarantine period. 1 on day 2 by RAT and 3, and also 1 by RAT, 5 on day 5 by PCR, and 1 on day 5 by RAT. Among the 13, 3 were from the UK, 2 from Singapore, 2 from Australia, 1 from India, and the UK, the Philippines, New Zealand, Thailand, and Canada, respectively. For the remaining 2 imported cases, they were identified on day 12 through a sample taken at Community Testing Center, 1 on the 29th of April arriving from Indonesia, another the 20th of April from Japan. Our preliminary investigation is that they could be positive cases. For genome analysis, the Public Health Laboratory conducted genome analysis on 79 cases. No L452 positive cases were identified, 74 negative to L402R, and the remaining 2 viral load was too low. There were no new care homes reporting cases to us, no matter whether they have had cases before. And for schools, over 2,200 schools resumed classes today. This morning, through our online network, 17 cases were reported to us by schools from 17 different schools. So there was 1 case from each school involving 12 students and 5 teachers or school staff. Among the 70 schools, there were 2 KG CCCs, 8 primary schools, and 7 secondary schools. Among them, 16 tested positive by RAT and 1 by PCR. 8 students had never returned to school after the holidays. 13 of the cases were with samples taken this morning, and 4 taken in the afternoon yesterday. As for death case, in the 5th wave, Hong Kong has noted a total of 9,115 death cases, up 3 from yesterday. The death rate in general maintains at 0.76%. For those who are 80, 10.46%. Hospital Authority, Dr. Lee, please. The HA has got 1,170 confirmed patients being treated at different public hospitals, Northland Town, ICC, HAIDC, and also AWE. 3 critical cases, 1 with no vaccination record, 1 with 1 jab, and 1 with 2 jab. 3 serious cases and 7 critical cases being treated at ICUs. We have death to report to you. 1 passed away on the 1st of May, a male patient. 2 passed away yesterday, 1 male, 1 female, aged 55 and 90 respectively. All of them were senior citizens, 1 from an elderly care home, 1 had no vaccination record, 1 with 1 jab. The younger patient who passed away on the 1st of May, I'd like to provide more information. He was 59, male with chronic diseases, with hypertension and renal failure, and also diabetes. In 2018, he had kidney transplant. He has got heart failure and also heart problems. On the 28th of April, he tested positive using RAT. He went to Penny's Bay Community Isolation Facility for isolation. On the 1st of May, at around noon, the CAD found that he was unconscious in his room. So an ambulance was called, escorted by HA staff. He arrived at the A&E department of Northland Town Hospital at 12:58. He was receiving resuscitation all along to the A&E department. On arrival at A&E department, no pulse was detected. We performed intubation. His blood sugar was low, and we had 5 shots to boost his heart. And then at around 2 p.m., he was confirmed dead. So our established procedure is to transfer his body to the public morgue, and the coroner's court will follow up. In the past day, 146 patients recovered, 106 were discharged. So far, 48,382 have recovered, 47,596 have been discharged. Over 60,700 odd patients have recovered, and over 50,000 have been discharged. 2 patients were tested positive upon admission screening, and 3 patients are classified as confirmed as close contact. 27,000 odd staff members have returned to their duties after being positive. Q&A, please. Please identify yourself and your organization. The gentleman over there. I'm from cable TV. I'd like to ask about the case of the 59-year-old male. He had chronic diseases, and he was sent to hospital from Penny's Bay. Whenever there is a chronic disease, given that the epidemic has eased, isn't it better for these cases to be hospitalized instead of to be kept at isolation center? I'd like to know whether on the morning any staff went to take his temperature to check on his condition. When was the last time a staff member contacted him? So when he was found unconscious, for how long you estimate he had been unconscious, and was there any delay in giving him treatment? Now, for the trend of the epidemic, we have 300 or so cases. So in the past few days, the number of cases hover around 200 to 300. And some experts said that perhaps COVID is endemic in Hong Kong now. How do you view this trend? Do you see the number of figures remaining at this level for a while? Some legislator said this morning that 6 mobile cabin hospitals will stop operation next Thursday. Is it true or not? So will the staff working there be sacked and become unemployed afterwards?
Answer the first question. The 59-year-old male patient, he had chronic disease, and the isolation measure, I'm not in a position to give too many comments now. The community isolation facilities are mainly the responsibility of Civil Aid Service. So for the details of what happened that morning, I think you may need to ask the relevant government department. But let me say here that based on our HA's information, by noon 12:51 p.m. on May 1st, we received the notice from Civil Aid Service about the patient being unconscious in the ward, and we sent medical staff to perform resuscitation there at the scene. And ambulance was called, and we accompanied the patient to the North Atlanta A&E department, and we continue to give emergency treatment to the patient on the way. Well, thank you for your question. As for the triage treatment, once we receive a case, notice about a case, we would use through two online platforms. One is the RAT platform, and the other is the PCR test platform to get information about the patient. If patient shows signs of urgency, then we would recommend on the online platform that the patient should be sent to A&E department and would ask for information on any symptoms or whether the person concerned is 70 years or above, or 5 years old or below, or a woman with 28 weeks of pregnancy or above. So we'll carry out some assessment to see and find out about the home situation, home environment, whether the person concerned is capable of self-care, and if there are any changes in situations, whether there are any possibilities of timely medical aid, and the home environment where there is independent toilet room for the patient. So we'll consider a series of factors to decide whether the patient can be quarantined at home or should be sent to community isolation facilities. So this is the risk assessment we normally carry out, but I'm not in a position to comment on individual cases here. As for the current trend of the pandemic now, in the past 4 days, every day, the number of cases was around 300. It's a stable level. In the past 2 weeks, we've seen that every day the number of infections seem to be on a downward trend. And through our monitoring system, we can see that the pandemic is stabilizing and seem to be on a downward trend. But still, right now, well, compared to the previous waves, we still have a relatively high number of cases. So our precautionary strategies now is to control the disease through, or the spread of the virus through social distancing measures, maintaining personal hygiene and vaccination. Hopefully, through these measures, we can suppress the number of cases as much as we can, because after all, the disease for high-risk individuals, once they're infected, say elderly people, the death rate or complications, chances of complications are high. So we hope that at this stage we can try to control the disease and adopt the method or strategy of dynamic zero infection. As for mobile cabin hospitals, I think the Public Security Bureau will be in a position to answer it. Your question on that. Next one, AM 730. As for community isolation facilities, you said that, Public Security Bureau, your comment on the trend or what's going to happen to the mobile hospitals, but in the future, if there are patients, more patients, where would they be sent to? And also, what about the staff? Where would they go? And you mentioned of the 12 students, 8 have not been back to school. The 4 students who have been back to school, when did they return to school? And were there any cases in their schools before? And yesterday afternoon, were the 4, did they give their specimen yesterday afternoon? And for the 12 positive cases, where are they from? And are any imported cases that have been now classified as local cases? Well, on the HA staff, right now, our community isolation facilities would actually have more staff centered at Penny Bay, the Penny's Bay quarantine facility. And at the North Lantau Hong Kong Infection Control Center will also be staffed. And we are preparing also staff for the possible sixth wave. And we have also got staff redeployed to our cluster to provide our usual services. Thank you for your question. On community isolation facilities, they will not be totally be put out of use. We will reserve some community isolation facilities because they do play an important role in actually quarantining patients who are not suitable to be placed in their home environment. And so they provide these isolation opportunities for those patients. And now, since the situation is a bit stable, numbers have come down, so some of the isolation facilities which were in use before would be in backup state now. But we will not close all such facilities because right now in the community there are still cases. And as for the figures about school cases, as I said, right now there are 17 new cases, of which 13 had their samples collected this morning. 4 had the samples collected yesterday. Of the more than 10 cases, 8 cases actually had not been back to school after the long holiday. And the remaining cases went to school yesterday. But of those who went to school yesterday, their RAT tests in the morning were negative. And after knowing that the result was positive this morning, they have not been back to school. As for the 2 cases discovered on the 12th day, the first case involved a 21-year-old male. He had 3 jabs, and he did not show any symptoms. Earlier on, in March last year, he was confirmed in Indonesia. On April 19, he came from Indonesia and on the flight CH798, and there were no other cases on the flight. And he checked into a quarantine hotel after his 7-day quarantine. During that period, all his test results were negative. On April 30th, on the 12th day, when he had a test at a community testing center, the result was uncertain, and the same sample was then sent to a laboratory for retesting. The positive was, and the result was a positive, but the CT value was quite high at 38. So we thought that this could be a really positive case. So we'll carry out genome sequencing to see what's the result. But because the viral load is too low, we may not be successful in doing the sequencing. Another case involves a 22-year-old male who was vaccinated. Actually, this is a case, in fact, recently overseas on April 2nd. He was in Japan and was confirmed. And April 20th, after he recovered, he took JL029 and arrived in Hong Kong from Japan. All along, he had shown no symptoms. He went into a quarantine hotel after quarantine. During the period of quarantine, all his test samples were negative. And then afterwards, he had a test at the community testing center, and the result was uncertain. And then the specimen was sent to a public laboratory for testing. The result was positive, but the CT value is very high at 38. His family members had no symptoms, so therefore we classified these 2 cases still as imported cases. The earlier 12-day cases, we received some results of genome sequencing, and 1 case was classified as imported cases before, but a few days later, we give you more details of the 45-year-old man who arrived in Hong Kong from Thailand. On the 12th day, his sample tested positive. CT value was 21. We sent the specimen to the laboratory, and we found that the variant compared to the strain circulating in the community is similar. Therefore, we classify it as a locally infected cases. We believe that after he finished his quarantine, after he entered the community, he became infected here.
Next. Good afternoon. I'm from Mingpao. I'd like to ask about the deceased, aged 59, from Penny's Bay. I'd like to know why he was sent to Penny's Bay isolation facility and not to a hospital. Is it because there was no bed available in a hospital? And I'd like to know the types of patients that will be kept at Penny's Bay. And with the case reported to the declaration system, I'd like to know whether he reported that he had renal failure and hypertension. Had he been sent to a hospital, could his life been spared? Now, we have seen patients who passed away during isolation quarantine. What is the HA's response? How can you ensure that there will be no repeated cases? And I'd like to know for the chronically ill, what sort of support do they have during quarantine or isolation? And if they're in trouble, how can they seek help? I'd like to talk about the tiered system under our arrangement. When we receive a report by the declaration system, we will give a questionnaire survey and to find out his health condition and to define whether he is a high-risk person and whether he is suitable for home isolation. If there is any emergency, of course, he should go to the A&E department at once. After we've collected basic information through the questionnaire, and if we confirm that this is a high-risk person and home isolation is not suitable, we arrange for him to go to a suitable community isolation facility. The patient has got some chronic diseases. However, his condition was not too bad. From HA's point of view, if the relevant parties need some screening, for instance, we can check the medical history of the patient concerned, that we can offer such assistance. Next. I'm from TVB. You mentioned a 59-year-old male who arrived from Thailand, and he was suspected to be carrying BA.2.2, and GOPC services have been resumed. I'd like to know whether the utilization rate has been high. Do you have any plan to reopen more general outpatient clinics? The man who is 45 years old, we've done some epidemiological survey. He has been vaccinated. He was asymptomatic. He arrived on the 19th of April from Thailand. He has completed quarantine. He lived together with 3 family members who have yet to display any symptoms. So we will follow our usual practice. We have issued an isolation order. He's suitable for home isolation, and his family members are also under home quarantine. We have not seen any suspicious things, but then after leaving his quarantine hotel, he has social activities. Perhaps he has caught it in the community, because there are still a few hundred of transmission chains in the community. So if he has been engaged in social activities, it's likely that he has caught it in the community. And for his family members, we have yet to have a positive report. We have got 73 general outpatient clinics, 7 of which have resumed services. We haven't got any information on the utilization rates, and we have to closely monitor the development of the epidemic to see any signs of rebound. And if this downward trend continues, we're confident that we can resume the normal service of our general outpatient clinics. Speaker is not speaking to a microphone. Speaker is not using a microphone. The speaker is not speaking into a microphone. I'd like to talk about our triage arrangement. If the case has completed the online questionnaire, we will have basic information on his personal health. For instance, whether he needs long-term care, whether he has high-risk factors, for instance, whether he is over 75 years old or younger than 5 years old, or a pregnant woman with over 28 weeks of pregnancy, 24 weeks of pregnancy, and also isolation at home would increase the risk of infection to other family members, and whether there are family members of a high risk that may have serious complications upon infection. These are factors for us to decide whether a person is suitable for home isolation. If the conclusion is no, usually he'll be arranged to go to a community isolation center, either the Penny's Bay or AWE. And if it is a patient that requires long-term care, then he'll be sent to a holding center operated by the Social Welfare Department. And if the patient has any serious condition, of course, he should seek medical health at once. The relevant information will be sent to the hospital authority for follow-up. Let's see if Dr. Lee has got anything to add. We have to look at it from two perspectives. Now, if a patient is staying at Penny's Bay Isolation Center, if we identify any change in his condition, and if there are things that the on-site medical staff won't be able to cope, he will be sent to either the Northland Town ICC or HA, IDC, or a hospital. But then arrangement for him to join isolation center doesn't involve the hospital authority. But if the authorities want the HA to help to make assessment, we are happy to coordinate or to cooperate. The press briefing ends here. The speaker is not using a microphone. The speaker is not speaking into the microphone. The interpreter cannot hear. I won't comment on individual cases, but usually, based on information provided by the patient, if we are of the view that the patient is not suitable for home isolation, he will be sent to a community isolation facility. Since that patient was sent to a community isolation facility, that means the information provided indicated that he was not suitable for home isolation. The PB ends here.